Okay, good afternoon, everyone. I think there'll be more people coming in as the keynote is finished. Welcome to everyone here, as well as those who are attending on live stream. This is the panel 2.10. We're excited about this one. Law enforcement and mental health strategies for effective partnerships. My name's Mindy Shreve. I'm one of the members of the steering committee for the summit, and I'm going to turn it over to Braden Schrag, who is our moderator for this panel. Thank you.
Thank you very much. First, I'd like to give a thank you to everybody here at the Eradicate Hate Summit, the Global Summit steering committees, our benefactors, donors, and everybody involved in putting this program together. I'd also like to thank my dear friend, Dr. Emma Cardelli, for inviting me and the rest of the panelists to be a part of this program and to help share some ideas, as well as our audience members that are both here today, as well as those in the virtual digital space. We thank you for being here and tuning in. I'd also like to thank my fellow panelists for their time in being here and sharing some of the great information that we have. So just as a quick, I want to introduce our team and give a little information on them so it puts some context to some of the things we're going to be talking about. Madison, I'm going to start with you today.
Thank you, Braden. My name is Madison Reed. I am the Director of Collaborative Public Safety Programs within the BC Ministry of Public Safety and the Solicitor General.
Okay. Jamie?
Hi, I'm Jamie Barrett. I'm a psychologist and I work for the Cambridge Police Department. I'm the Director of Clinical Services at Cambridge Police, and I'm also an assistant professor in psychology at the Harvard Medical School.
And Steve?
And Steve Thomas. I'm a lieutenant with the Anne Arundel County Police in Maryland, where I'm embedded into the mental health system.
And my name's Braden Schrag. I am a lieutenant with a major metropolitan police agency and also an independent consultant working on many of these issues that we're going to be talking about and you've heard so far today. Speaking of which, as you've heard from a lot of our panelists so far, and especially those that you who have been following the 2.0 track, you've heard how important partnerships are. And really, at the end of the day, they're an incredibly critical piece of what we need to do to address this complex local and really global issue of hate, racism, and all the other isms that go into kind of what we do here. I've spent nearly 25 years working in multidisciplinary teams. The vast majority of the time, they do exactly what they're intended to do. They allow us to think differently, act differently. They provide a measure of sustainability and give an opportunity and effort to really think differently about addressing these issues. The reality is there's no one entity, organization, or government institution that has the ability to address hate, racism, violent extremism, and any of these other activities. It really requires all of us coming together and operating in a space of trusted relationships, community engagement, and other partnerships with a diversity of stakeholders. There is a phenomenon that I've seen when we look at some of these issues, when we start working in a mental health partnership relationship, or law enforcement, public health, mental health relationship, and that's the notion of it's mine, not yours, and it's yours, not mine. And what this really goes to is when we start looking at these issues, they're complex, they're difficult, and we have concerns about liability, and there's also some territorial aspects that go with it, where I say, no, that's my issue to address, it's not yours. Or somebody will say, well, I don't really want to deal with it, it's your issue to address, not mine. And we can look at that in both law enforcement and our mental health partners, where we've seen that aspect exist. My own background has worked in pediatric mental health, social work, and law enforcement. So I've kind of sat on both sides of that issue of looking at whose responsibility is what. But the reality is, again, it's all of ours to address together. Some of the issues that come up when we look at these relationships are, establishing and maintaining barriers. Sometimes it's easier to establish and maintain a barrier that prohibits us from engaging with others and truly partnering in a collaborative effort with other organizations that are different from our own, right? The us and them mentality instead of a we. Sometimes those issues are as a result of responsibilities, roles, and mandates. Who has a mandate to do what? And if I look at it and say, well, it's really not my mandate, it's yours, not mine. Or somebody will look and say, hey, but you've got a role that allows you to engage with somebody, so it's your issue, not mine. Or if I want to take and look because of some of the responsibilities or mandates that I have, I'll say it's mine, especially from a law enforcement context. Sometimes we're guilty of saying, no, this is my issue, not yours. And then we try and impose our jurisdictional authority, positional authority, maybe on a mental health partner, and say, you are not allowed to do X, Y, or Z. And that really is a detriment to the patients, the clients, the individuals, and communities that may be impacted as an output of the violence that's committed by some of the people that we're working with. Some of the other issues that we face and we need to address are looking at common language. Each of us comes from a system that speaks differently. We may use some of the same acronyms, but they mean something very, very different. You may have entire phrases that are similar, but also have a different meaning. So really focusing in on how do we develop a common language, and that really comes in a collaborative space. Another thing is organizational and professional standards, right? Whether that's HIPAA, law enforcement sensitive, maybe something is classified, and these boundaries bind us and prohibit us from moving forward. And I know we're going to be touching on some of that with the use of MOUs and other ways that allow us to kind of peer into the other and make it a shared collaborative space to work with. Some of the other things that we have to take into consideration, and it becomes a mine not yours, yours not mine mentality, is liability. It's a challenge for some of our mental health partners to move into this space. There's a certain protection that comes with being a government employee and agent. We have these protections against things from occurring. We start moving into the private space or that consultative space, and there becomes this issue of liability. And working in these collaborative environments allows us to provide some of those protections to each other. And then the last thing is people and personalities. A lot of great programs are driven by a personality. They're driven by the people who are there. If we don't have some sort of model, if we don't have some sort of process by which we follow, many of the sustainability pieces fall to the wayside. And which brings me kind of to my last piece before I turn it over to my panels. One of the things that my colleague, Dr. Cardelli, and I have worked on is what we look at in this space is a 3C model. And that 3C model for us, as we've looked at our collective many years of experience in multidisciplinary teams and helping to establish them, refine them, provide guidance, or just our own work on those teams, this model provides sort of a practical approach to looking at what we're doing. It's a mechanism to guide our partnerships, to look at where we're at in the process of these relationships. And it gives us an ability to assess our activities and some of the progress that we're making. So we look at the 3C model. It's broken down to 3 pieces. You have concurrent activities where each of us is working in our own silo in the same space. We may be or may not be aware of who's there. But once you're in that space and you're working in the hate, violent extremism prevention arena, we start looking and saying, okay, who else is there? And in that concurrent space, I really only use the information, the knowledge, the access and resources within my space. I don't look at any of the other professionals for guidance or support. The next aspect where we move into, and this is kind of where I think a lot of people get stuck, is really in the consultative space. This is now we're aware of who each other are, we're working together, maybe we're on a multidisciplinary team of sorts, and we are taking and learning from each other. We're being informed about our practice. I'm learning about mental health activities and spaces, and it may be a referral mechanism, which is good. But we kind of get stuck in this space because the next portion that we move to is truly the collaborative space. This is where we really don't have any silos. They're pretty well limited. We have shared activities, a shared final outcome, a shared product, if you will. And it's also an ability to increase our capacity, ensure or better ensure sustainability, and then allows us for knowledge maturation. If we stay within our own system, if we stay within, the echo chamber that we know, we don't allow ourselves to grow. When we start communicating, coordinating, and collaborating with others, we allow ourselves that vulnerability to go, I hadn't thought about it that way. In fact, Dr. Cardelli and I, as we've done some work in this space internationally, have developed some curriculum together. We've sat down and spoken with each other. 2 very different systems, clinical psychologists and a law enforcement professional. And we look at what the other is doing. We've become aware enough of the different domains to say, have you thought about this? And there's been a few times I went, I hadn't even considered that. So changing that perspective allows us to grow the capacity of the individual, the team, and thereby the impact of others. So with that, I'd like to turn it over. I'd like to start with Steve. Steve is, as he mentioned, he's a lieutenant. He oversees a team of officers, and he is in a unique position to be embedded inside of a mental health environment. Steve, can you talk to us just a little bit about your program, some of the collaborative activities, and a little bit about what you see as we look kind of at that model, but what you've done to overcome some of those boundaries we discussed earlier?
Absolutely. So we are, I am a sworn lieutenant with the Antelope County Police, but I work at our crisis system, which is a quasi-governmental nonprofit. I think the important part is it's more than a partnership. It truly is a collaboration. My officers, the officers in my units, myself, a sergeant, and 8 officers, are embedded throughout the crisis system. We have and I'll give an overview of the system. We have a 24-hour warm line, similar to the National 988 system. We get about 4,000 calls a month into there. We have a mobile crisis team. We run 7 to 8 teams a day. They're on police radio responding to police calls for service. It's completely up to that patrolman, the supervisor on the road of when they get called out. It could be a traditional mental health. It could be a family issue. It could be the assist after a domestic violence. It could be the assist with a death notification, any traumatic incident we are responding to. It's really unlimited what we respond to. We have a program, Safe Stations. Anyone with any addiction to any substance can go to any police or fire station or call our warm line. An officer in my unit dressed just like I am, which is really important, the soft uniform, is responding with a clinician to get that person into recovery. The officer's job is we become the social support for that person. It may be that we are driving them to treatment. We're picking up their medicated assistant treatment. It could be that we're eliminating barriers in the criminal justice system. We work with our public defender, we work with our state's attorney and our court system to get warrants recalled or quashed to get people into treatment first. We even go as far as testifying for the person in their recovery. And it's really powerful. I call it the power of the badge when we do that. We have care coordinators that follow up to exactly what it sounds like. They coordinate the care for people who are mobile crisis team responds out to help patrol. It could be from a safe station. Think of it, someone's having a mental health crisis, they're referred to services, but is anyone helping them as a social support, as I have in my family, could help me if I'm in crisis to do simple things, schedule doctor's appointments, or it could be as simple as getting someone a state ID or a social security card, linking them to insurance if it's necessary. Then we have what we call our CIT unit. It's when we are running a traditional co-responder model of officer, clinician paired, and we are assisting people in the community. We're usually between 100 and 110 people we're working with extreme care coordination. It could be that they've been involved in the criminal justice system. It could be that they have a history of suicide, and we are there to be that social support for them. And a lot of times we're there to link them back to their social supports before they were in crisis. I think another part that I'm going to expand a little bit when we talk about what we do is we're creating a culture of caring. And what I mean by that is we also do peer support for our officers. We respond to all traumatic incidents to assist our officers up front with early intervention to assist them after traumatic incidents. We follow the principles of CISM, critical and stress management, of assisting officers. It could be as simple, and I hate to say as simple, but I'll reflect back in my career. The first SIDS baby I responded to, my daughter was 1.5 years old. I personally related to that SIDS baby. I can recall it like it was yesterday. Most people don't have that. So what we do today is we respond out to assist those officers after those traumatic incidents. We do individual one-on-one assistance, and we actually do group interventions as well. We treat the officers the same way we expect them to treat the community. and we've had great success with that.
Steve, do you think, you're talking about this collaborative approach. Do you think from like a behavioral modeling standpoint that impacts other officers that may not be involved in the crisis system, number one? And number two, do you think that also gives greater trust and willingness to participate in services by the community because they see a coordinated effort?
Absolutely. And I can give you an example. I got a phone call this morning from an officer that's having domestic issues with his significant other saying, hey, I think I need help. Can you link me to a therapist to get help? How important is that? And I think as through the whole conference, we've seen the significance of early interventions. And that's where I believe we're making a difference. As I went through and outlined the entire crisis system, but the officers in the unit are embedded in each part of it. So it could be when that call comes into the warm line that there's a question that the mental health counselor can't answer, but they can come over and get an officer who can answer it. Or it could be the mobile crisis team. Someone calls in to the warm line saying, hey, my loved one, I'm concerned they're having suicidal ideology, but I don't want a police patrolman come in. Well, we can send the officer dressed like I am in an unmarked car with that mobile team to respond, to assist. And part of it is helping, it's not just helping that person, but helping the entire family. We, and think of when I talked about safe stations, how powerful that is to the community when you have officers taking people to treatment instead of arresting them. And it's the people are asking for help. I'll give a quick crime number. The year before we started in the county, we had 1,824 burglaries. Last year, we had 725 because we are helping people help themselves, and we're just becoming their social support.
You know, you bring up that's definitely worthy of some clapping. You know, anytime that we can raise capacity, it's not just from a systems and structure capacity building, but you know, giving people our community members, everyday citizens that that do have a responsibility in general community safety, but empowering them to connect with others, to be engaged, and maybe recognize, report, caring about their neighbor, getting back to that old school mentality.
One of the other things we do is exactly that. And goes what you just asked. We were the first in Maryland major police department to train every officer in mental health first aid. We did that in 2015. The next year, we had a 21% reduction in use of force. Now, I'd like to say it was strictly from that. I'm sure there's other things there, but we also offer that same training to the community as part of community policing. And think of how powerful it is when we can go to the community and say, hey, you're going to get the same basic training that officers get to help your neighbor with mental health first aid. And we do respond, and it's really an important part of responding to those traumatic incidents. We were for a mass shooting at the Annapolis Capitol Gazette shooting, in which we had provided a comprehensive behavioral health response, not just to the officers, but to the survivors, their family members, the deceased, those that lost their lives, family members. And there's still contact we have with them. We actually did complete community, where we actually had a video went out through social media and the county TV station, helping families recover psychologically from that. Because when these incidents happen, as we know, it has an impact on the entire community. And when the police department can be the lead in our role at crisis response, as we're embedded into the system, it's extremely powerful community policing.
Absolutely. You bring up a couple things as a fellow law enforcement officer. One of the most difficult things officers have to go through is when they have to use force, and unfortunately there are times where deadly force is part of that particular interaction. To hear that crisis intervention, the training that's provided helped to do a reduction. Do you think that you're in a position too to help with further reducing some of that police use of force in that collaborative model? Because I know one of the most difficult things that I've responded to is somebody who is suicidal, who feels like they have nothing left, and now they have access to a weapon, mental health issues, substance abuse, high levels of intoxication. Do you feel that that approach, that softer approach, has an impact when you don't have certain tools that allow for less lethal options?
Absolutely, and we have, and I can go case after case of success we've had, where sometimes it's people we've worked with in the community already, had a relationship, where we've had barricade situations where our clinicians have worked hand in hand with negotiators for a positive outcome. We've also had other incidents where our officers are on scene and using the de-escalation techniques that we teach with a lot of success. As a unit, we follow the Memphis model for CIT training. And with that, it's not just the officers in the unit that are trained in CIT. I have another 206 officers. 26% of our department is trained in CIT. And we teach it as a culture that when an officer hears that call come out, they're trained in CIT, for them to say, I have the passion to help, I have the tools, and I should be the one responding. Our CIT training is not mandatory, and we don't want it to be. We just want those officers who have the passion to help, to get those tools, to be the ones to help.
And one last question before we move on to kind of bring it back around to issues of violent extremism and hate. In our conversations this week and leading up to being here in Pittsburgh, you and I talked about a couple of incidents where you guys have actually responded to somebody that really fits in this model. You talk about that engagement and maybe a little bit about working with what we might consider a perpetrator or somebody who's on the path to radicalization and all those precursors to violence, and working with those families.
Absolutely. So our number one goal is always to divert people from the criminal justice system to the behavioral health system. However, safety is paramount. And when the behavioral health system is not able to keep that person safe or the community safe, that's when we do utilize the criminal justice system. And we've had a lot of success with that, working with federal partners. We have a case right now where we're working hand in hand with the U.S. Marshals, the Secret Service, and ATF to do exactly that. And
I know that case is still ongoing,
yes.
So I'm not going to press you on too many details, but I think that's a great account. So kind of staying along these lines of that, placing people in different structures and systems. Jamie, I want to talk to you. As Jamie mentioned, he's a clinical psychologist, but unlike Steve, Jamie is a clinical psychologist actually embedded in a law enforcement system. So Jamie, can you talk a little bit about your focus, your collaboration, and how that works as somebody in a very different system providing the services and support that you do?
Yeah, sure. So I actually started working with the Cambridge Police back in about 2008 when the chief at the time didn't have a juvenile unit. And there was a high rate of juvenile arrest, and he wanted to do something about that. So he wanted specially trained officers, and he reached out to where I was at the Cambridge Health Alliance to get community partners to interview the officers to make sure we had the right people doing the job. And I started working with them on our juvenile diversion program called the Cambridge Safety Net Collaborative. And over a number of years, we were able to demonstrate success similar to what you're talking about, pre-complaint diversion, right? Getting kids before they hit the courts, using the community to come together and put a diversionary program in place, not relying on the courts, because once a kid hits the court system, can be anywhere as much as 7 times more likely to be involved in the adult system, right? So that collaboration grew and grew. Now, to your 3Cs model, that was collaboration, right? Grew and grew until in 2018, the commissioner at the time wanted to start a family and social justice section. And said, Jamie, we want to bring you on board to kind of head up the clinical support unit. So that's where I am now. We have a clinical support unit at Cambridge Police that I oversee. I have 2 licensed social workers and director of community outreach. So we're all non-sworn professionals. We're a unit of non-sworn professionals in a police department. We're dedicated to working with the vulnerable population. So juveniles, folks with mental illness, substance misuse, and our unhoused population, right? So our job is to follow up And I think when we talked in our phone calls, there's different models for different areas, right? So it's not one model kind of fits all or one model's the best. So in Cambridge, we use a case management and a follow-up model. So we review every incident that comes in that has to do with mental health or one of our vulnerable populations and assign a team of a social worker along with our specially trained police officers. We have a juvenile unit, we have a mental health unit, and we have a homelessness unit. And these officers are trained to go out and interact. Exactly similar to what you just said. Our goal is to deflect and divert away from deeper involvement in the criminal justice system. When I say deflect, I'm talking about pre-complaint, community-based, right? Before the charge happens, whenever possible. But we'll also divert. When I say divert, I mean working with the courts and in some way trying to formalize, right? I think when you think about this model of integration of psychologists and social workers working in law enforcement and targeted violence, there's two pathways sometimes we can take and sometimes we can access. The first is the mental health pathway, right? So when we have folks who do have a diagnosable disorder, and that is contributing to them making threats or getting involved in violent behavior. So we have a guy who has a bipolar disorder. When he's treated, he does great. When he goes off his medication, not so much. Recently made threats to President Obama, Trump, and Biden. So he goes across the political spectrum, right? He's not
Full
going
opportunity.
but he hit them all. And made some threats to the FBI as well. And when you threaten the FBI, they tend to take that very seriously. So I went out with them to try to get this guy into the hospital. And I also didn't know when you go to the FBI, all of a sudden there's these like really large dudes in backwards baseball caps and vests that kind of come out of the woodwork. It's like, oh, okay.
I think we've got some.
Let's see which way this goes.
Yeah.
So we were able to get him with his mom's help into the ER, and I've done many in Massachusetts, a Section 12 involuntary commitment. But it's the first time I brought someone to the ER, and you hear the nurses say, "They brought this guy in with the FBI." So it kind of just ramps up the concern, right? So the point is, mental health pathway. Sometimes we can get people to treatment, we can get them stabilized, and then the threat or the violence reduces. Now, we know that's not the majority of cases, though, right? And it's very important to say that. In fact, there was just a systemic review, a meta-analysis that Campbell Systemic Reviews put out that shows if we're talking about terrorism, the populations involved in terrorism, the rate of mental illness is no higher than the actual population, right? So it's kind of a small group. The FBI will tell you up to 25% we might be talking about. There's a diagnosable, treatable mental illness, right? So that's the mental health pathway, we can use it. The other one's the forensic pathway. And there are times when we use criminal charges when necessary to leverage some kind of involvement in, whether it be counseling or sometimes counseling's not going to work. And in this, over these 3 days, learned about a lot of different off-ramps to, violent behavior or extremist behavior, and to be able to leverage those using the courts, using a charge, to try to get cooperation. And I think the other piece is, though, you have these really difficult cases, right, where there's not a lot of cooperation. You're talking about juveniles and, the parents don't want to cooperate. There's a lot of resistance. And it's really hard to think about what can we do to keep everyone safe. I think to your point, when our common goal is safety, right? How do we work together around this? Because there's no easy answers. And so I'm really fortunate in Boston, we have the Mass Bay Threat Assessment Team through the FBI, and some of the members are in this room today. And it's a tremendous resource that we can meet on a Zoom call and discuss these high-risk, very complicated cases and, kick around ideas, right? We don't always agree, but that's important because it's just, there aren't easy answers. And so if you think about, in Boston, if you have a really difficult cancer case, we have something called the tumor board, where the experts all meet and consult and come up with different treatment plans for the hard-to-treat cases. Now, the team that's going to treat that patient, they still own that case, but we act in a consultative model. And so this Mass Bay Threat Assessment Team model for our work has just been really invaluable in being able to think together, because there aren't easy answers. We know it gets complicated when you're talking about the intersection of social services, law enforcement, people posing threatening behaviors, and how we best work together to kind of mitigate that risk, but also keep everyone safe and keep potentially the person safe who's accused of making a threat, and not be unintentionally harsh on them.
Great. You made a comment about diagnostic criteria that only about, according to the FBI, about 25%.
Yeah.
The rates are really no different than anyone else. Given that, obviously somebody could look and say, well, does the mental health system really need to be involved?
Yeah.
Give me your thoughts on the fact that, you may have historical traumas. Somebody may be going through crisis. They don't necessarily have a diagnostic code,
Yep.
attached to it for a service provider.
Yep.
But they're still dealing with some of those behavioral health issues. Do you see a role still for some of that involvement and, to help continue with those diversions and preventions early on?
Yeah, absolutely. So, and it's a really difficult question, and we just had a training for the Mass Bay Threat Assessment team. We kicked around this idea, right, of that it's not all mental health. But then someone who wants to shoot someone, you can't say is mentally well adjusted, right?
Exactly.
So it's like,
exactly.
And
Yes.
I was having this conversation with actually one of the social workers who works in the unit after Uvalde, because she kind of went on this big mental health thing. I was like, well, I don't know if that person would have been captured in the mental health system, and she was kind of coming back. And I said, well, no, I don't think you're getting it. It's not all mental health. And she said to me, I don't think you're explaining it well. And I was like, that's fair enough, because it's a nuanced, difficult, we start to talk about mental wellness, or we start, most recently we're talking about stressors, right? There's stressors in people's life, and kind of parsing out this language. I think the important thing is we don't want to overly stigmatize those with conditions. And that's what I worry about when we hear is mental health is mental health. Make sure people with mental health problems don't have guns. Make sure we can look at people's hospital records, make sure and that's not the route we want to go. But absolutely, if we're talking about people at risk for violence, they are going to have problems, stressors, poor coping, really rigid beliefs, and there are still avenues for mental health and for providers to intersect and work with those folks, even if they don't have a diagnosis. Part of the thing I'm thinking, like DSM-6, maybe we make a new diagnosis for this, so we just stop having this argument. Like really dangerous, violent people. Might just, I don't know, contact me.
RDPs?
Yeah.
RDVPs? So real dangerous, violent people. There we are. I'm sure we've got some minds in this room who can help us with navigating the APA and a few others to get it in there.
DSM-6 people. Hit
There
me
we
up.
are. Yeah. Version 2.0.
Right.
That's right. So, thank you very much, Jamie. As we've heard from both you and Steve, the importance of that collaboration, being in these different structures and systems, and really being able to demonstrate great success, and being able to reach out and leverage some of those other resources that if we stayed in that, that very siloed area, we may not have the success. We may not be able to reach out. We may not be able to ask that question. And I think, something you mentioned about the Cancer Board is with these complex issues, there may be a collaborative, but there's also some movement between that consultative and collaborative space, because there's still going to be things that reside just with mental health practitioners, or just with law enforcement professionals, or just with insert any other partner on the team. So I think that's also important too, to think about that, we need to look at ourselves moving from just a consultative activity into that true collaborative space. Right. But realize that there are going to still be times where we're going to have to be a little emotionally or professionally flexible to move into some of those different spaces. So transitioning from the frontline practitioner piece, I'd like to talk to Madison now. And Madison is with British Columbia Public Safety. She's in a leadership role and has program oversight, kind of setting the stage for some of this to actually occur. And so could you just talk about your efforts, maybe touch on the importance of MOUs and how we can create these spaces that give us access to work in a collaborative?
Absolutely. So thank you very much. As I mentioned, for those of you who came in a little late, I'm the Director of Collaborative Public Safety Programs with the Government of British Columbia. One of those programs that I particularly want to highlight today is Shift BC. It does sit within the ministry, and it was founded essentially in 2017, but we began accepting participants in 2019. And we host that program with the support and co-oversight of the RCMPE division, which is our provincial policing body. RCMP, but provincially located. I'll get into that. There's a few differences between Canadian and American policing that I think are relevant, as well as Canadian intelligence, as well as the Vancouver Police Department, and then a few of our major municipal cities, such as Vancouver and Surrey as well. So I'll leave that up as I speak, just for your background. I want to highlight that 14% of our total budget is earmarked exclusively for evaluation, so both of process and impact. That's something I'll talk a little bit about, but something I think that's very important. And our primary focus is to reduce the risk of extremist, not only extremist events in British Columbia, but essentially targeting macro outcomes such as that, obviously you can't prove a negative, through micro interventions. So we function at the secondary level. So that means we work with individuals who are already starting down a path of radicalization to violence. I'll get into our referral process in a little bit. But we do work on an individual resiliency level rather than work in the primary space, which is general education. And we also do a little bit of tertiary work. So we work with people who have been incarcerated, for example, for related offenses of a relatively non-violent manner. I feel that the ministry, so the government, is an ideal administrator of this type of program due to its pre-existing relationships as a key funder, a legislative authority, stakeholder at the very least to other government bodies, NGOs, nonprofits, the social sector, as well as law enforcement, of course. We also have access to administrative and other data that can help inform best practice as well as evaluation. So put another way, we're a risk reduction and individual resilience pilot program, as I said, aimed at achieving macro outcomes through micro interventions. We work very closely with law enforcement partners, and just for context, I do want to draw your attention to the fact that even before our inception, our program was in a privileged position, essentially, being situated in a government ministry. So as I mentioned, our ministry is responsible for public safety in general, but related to this topic in particular, we're responsible for ensuring that an adequate and effective level of policing and law enforcement is carried out and maintained throughout the province. So our ministry is responsible for setting the goals, the objectives, and the priorities for policing and law enforcement in BC, and our branch in particular administers the RCMP contract. So I will take a moment just to explain, in Canada, the lion's share of our municipalities, which are comparable to US counties, are policed by the Royal Canadian Mounted Police, and that is a federal institution that is essentially run by the federal government at arm's length, obviously. Individual provinces can choose to contract out that entity. So BC is one of those provinces. In fact, the only province that doesn't is Ontario. And then on a lower level, municipalities can then choose to take the contracted detachments from the province, or they can choose to institute their own municipal police forces. A few have chosen that, particularly in larger urban areas like Vancouver, for example. They have the VPD. So with that context, because of our longstanding tight-knit relationship with the police, we work with them on a daily basis from everything from, serious and organized crime, contracts, policing matters in general. We have had that relationship that did not need to be built with this new program that was designed at getting at violent and hate-motivated extremism. So we didn't have some of the challenges that I know my colleagues and NGOs and nonprofits can face when working with the police, but I seek to essentially use that privileged position to have a roadmap or a way forward for other entities that are coming on and into this space. I will also mention BC does have a program very similar to yours, Steve, but that's not necessarily related to hate-motivated or violent extremist violence, but I really enjoyed listening to you speak because I think it's a very powerful way of doing things.
Thank you.
Okay, moving on. So the first thing I want to talk about in terms of walking you through, I don't want to paint too rosy of a picture. It was easier for us given our relationship, but it still was not easy. It was an absolute slog, in fact. So, it was there was an agreement in principle before SHIFT was ever even funded that, intelligence, RCMP, VPD, all committed to participating in this program at the executive level. So we had buy-in, but when it came time to make the first referral, everyone was like, "Oh, okay. Well, actually, how? How are we going to do this?" There's a lot of different issues at play, right? So, I have 3.5 steps that I want to talk us all through. So the first one is building trust and rapport. So this is done through consistency, boundary setting, and building strong collaborative frameworks. Our field is in its infancy, and therefore many of the policy and protocol infrastructures which are taken for granted in other peripheral fields don't yet exist. As we've heard this week, for example, at yesterday's session on the ethics of building CRV and anti-hate programming, there's a lot of question marks that remain in our field. And as a result, individual relationships built on past partnerships and built on trust are often used to fill that void. That's what programming is based on. That's what policy is based on. So one of the ways that we quickly learned to do that is we realized we can't step on any toes, particularly with the intelligence community. One of the ways that we built that system in is through our referral channel. So in SHIFT, referrals, off the top of my head, 94% of our referrals come from law enforcement and intelligence referral channels. And because we are non-punitive at SHIFT and voluntary, generally what happens is there has been an investigation from law enforcement. They are then going to close that investigation without charges being laid. And that's the key part. So we're not necessarily a court-mandated program. Once it's determined that no charges will be laid, there's still an acknowledgement that the case could escalate or become worse if the individual does not receive, social supports, mental health counseling, etc. And so they will often close the case, refer to us, and then we take it from there. As I probably don't need to tell any of you in this room, it was not a popular thing to say to police that we will not share any information back with them. That did not go over well. But I think this is where boundary setting comes in, and it's very important. And if you set your expectations at the beginning, make sure everyone is consulted, everyone's on the same page, we eventually were able to say, look, in order to make a voluntary program work, you absolutely must have buy-in from your participants and trust of your participants. Because we are an in-between between where police action stops and where pro-social support and intervention happens, we were able to say what we will do, though, is if we see this individual escalating, just like anyone who with a duty to report, teachers, nurses, doctors, immediate harm to self or others, we will do that. So if we see escalation that becomes a policing matter, we will let you know.
Have you had any that have risen to that?
Actually, we've had the opposite. So I was just about to get into, we also acknowledge that there are times when they have received intelligence, particularly with new referrals and cases who are, obviously people are various levels of willing to engage with the program. Many of them will say yes and then slowly ghost you, over time. Yes. So there's that constant pull of trying to get people to engage. So we have had it where they have called and said, absolutely, you need to stop meeting with this individual. Your staff is at risk if you continue. We have received intelligence. So that's actually happened twice.
Okay.
And one of them, unfortunately, did result in the person needing to be incarcerated for a violent incident.
That sounds like one of the key issues that we face in this arena, and that's information sharing.
Yes.
Steve, you had mentioned to me that you reside in a mental health space with HIPAA rules, and you have MOUs, and you've been questioned, hey, what's going on? And you're like, I've got access to it, even as a law enforcement officer, but I can't tell you because it's not yours, and you've got kind of the same, but you've got mechanisms that duty to report, duty to intervene type.
So even with us, we actually sign confidentiality agreements with the mental health agency. So I have full access to the mental health records, the same as the clinicians have. We do everything in collaboration. But what Braden said is command in the police department could call me and say, Lieutenant, what is happening with this case? And I have to say, I'm sorry, I cannot tell you. On the same sense, though, if there was a danger to the community, it would be a different set of rules.
Yeah, so different systems, different structure, but same output because of setting those roles, responsibilities, mandates, and having clear boundaries.
Having clear boundaries.
Okay, please.
Next, develop protocols to navigate information sharing and privacy challenges. And this is while respecting both the spirit and the letter of related legislation. So some of you may know Canada has some of the most stringent privacy laws in the world, to the point where I would say it sometimes can cause detriment to sharing information where there is great benefit to an individual to be had. And so I think, overcoming that in this setting while still adhering to the importance of maintaining privacy, particularly as these programs can be very alienating and, of course, very damaging to the ability of the individual to go about their daily lives. And certainly, losing that trust with our program would potentially even push them further down that negative path. So again, one of the ways we were able to do that, we've been able to create landmark MOUs. It's called Partners in Justice, and we have signed it with not only law enforcement, but with other government ministries that are responsible for health, education, social services, welfare, et cetera, and nonprofits. So it essentially, within the very structured setting of a situation table or with Shift, nonprofits and law enforcement entities can share information for the common good of an individual. That is groundbreaking, and I hope that can continue across Canada, and I know some of my colleagues are working on similar things in other provinces. Just want to be conscious of time. But I really want to say it is a long process. That MOU took us over a year, and I had a staff member working on it full time.
Oh, geez.
And it wasn't that they didn't want to. I mean, the law enforcement has their own lawyers, government has their own lawyers. Everyone wanted it, and it still took a year. So if you're not in that collaborative space, good luck.
Exactly.
That's all I have to say. And then have a convincing narrative of mutual benefit. So you got to have a story, a strong, why should the police be involved? Why is this important? What are the outcomes that can help social sector, government, and law enforcement if you have these models? And obviously we've heard some of the benefits from my colleagues, but there is a gap between cases where criminal charges can be laid and whose RCMP and intelligence mandate just doesn't cover, but who still need support and positive intervention. In BC, 70% of calls to law enforcement are not policing matters. 70%, 70. I'm sure it's very similar across other jurisdictions. We can say, we can help you with that. If we can focus on the upstream, it frees up policing resources to do core policing matters, which is immediate threats to public safety. That is what police are designed and trained to handle. Anything else, they're not designed and trained to handle, and we've seen the negative outcomes that happen when you ask frontline police officers who are not equipped to handle acute mental health issues on the front line. So that's what we seek to do as well. And then 3.5, the importance of bringing financial ROI to the forefront. This one gets you very far in government, and it gets you very far at the executive level. So we've had a net return on investment of $13 million to law enforcement since 2019. That's net. So that's not even counting what it costs to run our program. And when you have data like that, it gets you a long way in terms of continuing these programs. And I guess in closing, what I want to say is that we've also trained hundreds of law enforcement personnel. We bring them to the table. And when I say train, we don't just train them on, CRV, hate-motivated violence. We've done things like working with trauma, working with refugees, working with grief, working in trauma-informed ways and recognizing what that looks like. We've done how to recognize a potential school shooter and how to de-escalate those situations, for example. We also invite them to the table. We have an annual academic conference, and so we try and get law enforcement personnel in the room, frontline law enforcement personnel, with academics, with researchers, and with government policymakers, as well as social service sectors, so that they can inform and learn from all of one another. Because I think in spaces like this, too often we don't have anyone from the front line. This is obviously not the case here. But in most academic conferences, unfortunately, that is the case. And the spectrum of radicalization to violence and hate-motivated violence It's a symptom of wider societal problems such as social polarization, unaddressed mental health concerns, digital illiteracy, and socioeconomic realities. And I think a multidisciplinary approach is required to combat that problem, but law enforcement remain a key part of it. And so, we can either choose to exclude each other, or we can choose to try and make each other better and to give everyone a seat at the table. And we have to move from reactive to proactive, and I think this is how we do that.
Absolutely. And you were going to touch on a point, and that is, we have these different skills and abilities, but we've got to bring them together.
Yes.
We're going to be just a moment over, but in a quick rapid fire, if I know that I've got 50 minutes, I'm going to take all 75. So in a quick rapid fire is kind of a closeout for each of us. What are the one or two things you would want to share with those actively involved in or looking to develop a multidisciplinary team with those mental health, law enforcement partnerships, or is there something else to consider? So, Madison, let's start with you, and then
I've covered, yeah.
All right. Steve.
I think it's relationship building. It's working with whatever resources you have. And as you heard, we're all from different areas, different segments of government. For us, our county, my police department, 800 members of the department, we are the only law enforcement in the county. So it's easy for us to go right in and blend into and be integrated into the mental health system where, again, they're one agency for the entire county, where other places are going to have multiple jurisdictions. Some of our neighboring counties may have 25 police departments because of all the small towns. So it's really not, they can't necessarily do exactly what we do. You have to make it work and fit for whatever resources you have where you're at.
So a principle-based approach rather
Absolutely.
than a tactical-based
Absolutely.
approach. All right. Jamie.
I think, real quick, I think the model of integrating law enforcement and mental health is really critical, because even the point you brought up, Madison, where, police are ill-equipped to deal with mental health crises, not all the time.
No.
There's this
Absolutely.
intersection
Yeah.
of criminal justice and public safety matters and mental health that will never go away. And so even in my model, we had some opponents say we need to completely separate law enforcement and civilian-based approaches. It's never going to work that way. At 2 a.m. when someone's in crisis, you don't know what that deal is, and you can't just send a social worker in, right? No. So integration, what will allow you to do is it'll allow, if we have better civilian response and mental health response, for police to focus on those issues where there's that intersection of public safety and mental health. And that's where we need to, I think, focus our attention when we're looking at this problem.
Yeah.
Excellent.
Braden, if I can add one thing.
Yes.
Most importantly might be finding the right people that have that passion to help.
Yeah.
It's finding and changing the police culture, or I shouldn't say, but the perception that police must be helpful, not hurtful to people in times of crisis, and finding the right community members and the community partnerships that have that same passion to help.
Excellent point. And I'll just finish by saying, I really think, as I've looked over roughly 25 years of multidisciplinary teams, looking at that 3C model as a guide path to get you to that collaborative space is critically important. So with that, I want to thank all of our participants in virtual land and everybody that's here today. And I want to thank my fellow panelists and everybody at the Eradicate Hate Global Summit 2020 for an incredible experience as we close out our final day. Thank you all very much.